good afternoon. I think we'll get started. So thank you so much for joining us today for Innovations in ED Bupe for the treatment of OUD. And I'm so excited that I'm here with some very, really rock stars in the field, and I will introduce them in a minute. We have no disclosures, and so I thought I would just set the field right away by things that you already know, that drug overdose deaths have continued to rise, and they are escalating every year. So no matter how we're all up here trying to fight this real epidemic, we're not winning, that's for sure. So last year, ending 11/2021, we had over 106,000 overall deaths. We know that those deaths, I don't know why that did that. We know that those deaths are primarily coming, as you can see there, from synthetic opioids. So of fentanyl, which is over 70,000 people are dying each day. We have less people dying of heroin, but that is really only because they've moved on to the fentanyl and fentanyl analogs. And clearly we're having a lot of psychostimulants, primarily methamphetamine, that has gone up 36%. So overall, we're up almost 16% in all drugs, but clearly very up almost 25% in synthetic opioids. So as you know, this is a problem because people die quickly. This is a brand new slide just to show you if you age adjust the drug overdoses by age, sex, and race and ethnicity. And I thought it was kind of interesting if you take a second to look at this because it's looking at pre-COVID, COVID, and after COVID. So if you can see really in all age groups that all age groups were, I'm trying to see if I can get this. Here we go. So all age groups really started to increase before COVID. So we always think COVID, of course, is escalating everything and making everything worse. Everything was going up pre-COVID to begin with and then just really took off. So if you look at males that are between the ages of 15 and 35, and you can see over here on the axis, this goes up to 65 per 100,000 population. When we get to the females, the scale changes, so you can see, just so you can really look at it, but it's obviously a much more male prominent death. So if you look at the 15 to 34-year-olds, you can see up here is the major ones here, or the non-Hispanic American Indian or Alaskan Natives, and non-Hispanic whites, which are here, and blacks. So this is where we are. If you look at the females in this group, it is really all the American Indian or Alaskan Natives that are really escalating. When you get to the 35 to 64-year-olds here, as you can see, this is where we have the most, a majority of deaths, and those are really both the black population, Native Americans, and Alaskan Natives. So this is really where it is and where we're focusing a lot of energy in. And in females, again, it's really escalated from the American Indian, Alaskan Native, but we're catching up here in terms of black. So it's really a problem, but before, where it was a primarily white disease, we are seeing these escalations in all these other racial and ethnic groups. And we are seeing actually more adolescents even as we speak, so this will come out later, who are unfortunately getting a hold of a lot of illicit fentanyl, thinking they are other pills like Percocets or Vicodins. So with all that background, then we also know that very few people are being treated. So of 101.6 million people that are age 12 and older that have opiate use disorder, only 18% of those receive medications for opiate use disorder. And we know that by far the most efficacious of those medications are agonists, so methadone or buprenorphine, and where naltrexone has come onto the market is less efficacious than the other two, and really retention involves about getting people started, and that's where we all are at. So most of the time the patients come to the ED because that's where they are, and we should be treating them. So I have these really wonderful presenters here today, and I'm going to introduce them very quickly to you, and then they're all going to present. So all of us up here are boarded in addiction. I'll start with that, and we're all emergency physicians. Dr. Hawk is an assistant professor in the Department of Emergency Medicine at Yale University and as an attending physician at Yale New Haven Hospital, and she is really co-leads the ACEP Emergency Medicine Quality Network Opioid Initiative. Her research interests are in overdose prevention, harm reduction, stigma, and the initiation of treatment for substance use disorder. She is on many investigative projects. She was a co-lead on the NIDA clinical trials lead for what we call 79, which was BUP initiation, implementation in under-resourced areas. And she is also a co-investigator in ED innovation, which we'll be talking about later. Dr. Andrew Herring. Dr. Andrew Herring wins because he's also boarded in emergency medicine, and pain. And so he is an associate clinical professor at UCSF. He works at the Highland Alameda Health System in Oakland, California, where he is the director of research. He is also the medical director of Alameda's Restorative Pain Clinic in the past, and is currently a director of the Bridge Clinic and Substance Use Disorder Program at Alameda. He is the co-founder and co-director of California Bridge, one of the largest state-level efforts to promote access to the medications for opiate use disorder in hospital settings. And he is a co-investigator on ED innovation, which we'll talk about, and the principal investigator for the Public Health Institute California Bridge Outcome Study. And Dr. Rachel Hawk is an associate professor in the Department of Emergency Medicine at Cooper Medical School of Rowan University and division head of toxicology and addiction medicine. So she's also boarded in toxicology, addiction, and emergency medicine. She helped build and now staffs the Center for Healing at Cooper University in Camden, New Jersey, which is a substance use disorder clinic dedicated to treating patients with compassionate and evidence-based treatment and integrating patients with HIV and substance use disorder. In 2016, so that was like really right after the first article came out around ED-BUP, so this was really an extreme innovator. She helped create and implement BUP First ED, an initiative to prescribe BUP from EDs and bridge clinics to various community partners. And in 2019, she helped launch BUP First EMS, an innovative program aimed at initiating buprenorphine via paramedics in the field. So I am really excited to have these rock stars here, and they are going to talk about innovations. And Dr. Hawk will talk about injectables, buprenorphine, and then we'll move on to Dr. Herring with high-dose buprenorphine initiation strategies. And then finally, we will have Dr. Harag, who will talk about out-of-hospital BUP programs for EMS. So they are going to talk for about 12 minutes or so. We'll have a couple of minutes for questions. Then we'll continue to make sure we get through all three, and then we'll have more opportunity for questions at the end. So here we go.
Thank you so much. Can you guys hear me? Okay, perfect. All right, so ED-initiated buprenorphine is likely a not new concept for many of you in the audience. We certainly know that it is effective for initiating treatment for opioid use disorder for patients in the emergency department, but the traditional induction strategies using sublingual buprenorphine does present some challenges around patient providers from an implementation standpoint. So from a clinician standpoint, we certainly know that a lack of sort of the Data 2000 waiver is a barrier to writing some ongoing prescriptions outpatient. That is certainly better now with the recent changes that made it so that physicians are not required to have the 8-hour training, but you still actually have to submit a notice of intent to SAMHSA, and so that still is a barrier around initiating treatment. And there's certainly lack of prompt access to community treatment or providers, particularly if you don't have anybody to write a prescription. From a patient standpoint, we know that many of our patients, they're complicated patients with complicated lives often, and there may be issues around sort of insurance or prior authorization, having a photo ID to pick up a prescription at a pharmacy or just getting to a pharmacy the next day, transportation. We certainly know that for many folks that when they arrive in the emergency department, they may or may not actually be exhibiting signs and symptoms of withdrawal, and so they may not be actually ready to take their first dose in the emergency department. So if you can't get the medicine to them, or if they can't get it to the pharmacy, you've sort of missed your window or opportunity for initiating treatment. And then, there certainly is some ambivalence around initiating treatment many times with some of our patients. So there is, in some ways that's something that we certainly want to capitalize on is clinicians, where we can say, even if you're not sure, I'm going to send you with a prescription, and so it's there if you're ready. But if folks are sort of ready to initiate treatment and to sort of get on the wagon, or whatever you want to call it. You certainly want to be, have options around doing that. And injectable buprenorphine, particularly the extended release version, sort of provides an opportunity to, give them 7 or 30 days worth of medication sort of right from the emergency department. So, as I said, extended release buprenorphine, it offers sustained levels over time, and it does address actually many of these barriers. So this is a review of several of the different sort of long-acting buprenorphine products. So one is the 6-month implant, which likely will, folks are not doing in their emergency department, but it's sort of around and available, is for folks who have been stabilized on sublingual buprenorphine, and overall actually meets a fairly low bup concentration. It's about equivalent to about 8 milligrams daily of buprenorphine. So probably less helpful in the age of sort of higher potency fentanyl and medications. So there's also a monthly injection called Sublocade, which is available in Australia and the USA. It is a 30-day injection. It comes in 100 milligram and 300 milligram doses, which sort of get to that level of sort of 3.2 or 6.5 sort of concentration in nanograms per milliliters. It is FDA approved for treatment initiation after people are stabilized on sublingual buprenorphine for 7 days, although we certainly have a number of clinicians, including our folks here, who have used it for initiation from the emergency department. So that's certainly an option that is available, but it's technically off-label. And there are actually studies, I think, that are being conducted around using that for initiation. And the one that we're going to talk a little bit more about today is this medication, Buvidal or Brixadi. It's also known as CAM-2038. And part of why we're sort of talking about that today is this is the medication that's being used in probably, I think there's 4 NIDA clinical trial networks across different patient populations, emergency department, inpatient, patients who are pregnant. And it has both a 7-day and a 28-day version. It has passed safety through the FDA, but is not currently available for commercial use in the US right now. There's some delays around sort of manufacturing, but we expect that it will be available shortly. So I'm going to talk a little bit about, so CAM-2038, so it is, it's certainly a small volume. It comes in a prefilled syringe with a very small needler. It is administered by a provider. It's not something a patient can pick up at a pharmacy and self-administer at home. So it's certainly something that you could give in the emergency department. And as I mentioned before, there's sort of a weekly and a monthly dose. And the preclinical trials around this medication and their application for FDA approval actually were done for treatment initiation and not just for continuation as the other longer formulation. And so as you see here, there's sort of 8, 16, 24, and 32 milligram for the weekly version. For the clinical trial, I'm going to go through just a couple of cases where we've used this medication for initiation or treatment induction in the ED. And this is really cases that have come from our ED innovation, which Gail mentioned before. We had sort of 2 components. One was something called the ancillary study, where we were just observing people over a longer period of time, collected more sort of data around how people did over 4 hours after getting the injection. And we actually did that in folks that had lower CAL scores. I think you're going to talk about that. You have an abstract about that at some point?
Not well.
Anyways, so there's one, yeah, so the ancillary, yes. So the ancillary, where we actually gave it to folks who actually had quite low CAL scores, and used that to inform our randomized controlled trial, where we actually administer this injection to folks who have a CALs of 4 or more in the emergency department. So with that, I'm just going to go through. So this is what it looks like here. It's a pre-filled auto-injector. You just pop it off and follow the directions. It's very, very straightforward. We were quite worried about sort of having to do a lot of education with the nurses. Turned out to be not a big deal. They were very comfortable with this, and that was pretty straightforward. So as you can see over here on the left, this is the plasma buprenorphine concentrations of sort of the lighter colored gray is sublingual buprenorphine of 16 milligrams. And as you can see, there's this huge sort of uprise in the first 20, 30 minutes, gets up to about maybe 5, 5.5, and then sort of slowly tapers off over the course of the next couple hours and drops down to sort of around 1 nanogram around 24 hours, whereas you can see the darker line is the 7-day injectable formulation, which has this sort of slow rise, which is part of why we think that it's been particularly successful at doing a treatment initiation in the emergency department, particularly with people who have cows at lower doses than we would tend to start sublingual initiation. So this is sort of over here. You can see I mentioned there are two different formulations. There's 24 milligram, 32 milligram. So over here on the graph on the right, you can see sort of again the plasma concentrations rise after getting the injection on day 0. The bottom one is the 24 milligram, and the top one is a 32. And then this is lasts for 7 days. And then at 7 days, they when you get a repeat injection, your levels go up again. So like with all injections, it is not, the 7 and 30 days is, that is sort of the recommended. There are certainly cases where people do better, where people need a little bit, they may metabolize faster or have withdrawal symptoms sort of shorter or longer, but those are, really things that you want to just think about and communicate with your patients, as you think about sort of from a follow-up standpoint. So I'm going to talk about a couple of cases. So this is to a couple that was actually enrolled at one of our sites in Pennsylvania. And so this is a couple who was referred to the ED from a syringe exchange clinic who was unable to initiate new treatment induction during COVID. They had escalating use of street oxy for a year, and were using 5 to 6 pills a day by instillation. So social history, they just can't afford the $100 a day each anymore, and they do have a 3-year-old daughter in their care. And so these are folks that were actually enrolled into the study. And part of why I mentioned the ancillary before is so we actually followed their withdrawal symptoms over 4 hours very, very closely. So that's why we sort of have what happened with their withdrawal over the course of 240 minutes. And so they initially had a CALS of 7 and 6. They did a urine toxicology, was positive for opiates and fentanyl. I should mention methadone is an exclusion to be enrolled in this study and to receive this medication. And they were both enrolled together, about 30 minutes staggered. And so as you can see, sort of the top row, 30 minutes in, the CALS was still around 7, and then sort of went down to sort of 2 or 3, and then went up a little again, and then down again. There is certainly some fluctuation that you see. I'm sure many of you use the CALS score and are aware of the fact that, there is a lot of subjectivity, and there's a lot of challenges around sort of using it, but it is, we have to use some scale, and so, that is what we've been using. And so, in general, this is somebody who did sort of very well with the injection, and overall felt better at the end. The second person, as you can see, had a slightly different sort of trajectory of improvement in their withdrawal symptoms, but in general, you can see that even as fast as, so for sublingual, you can have abatement of withdrawal symptoms within sort of, people feel better in like 15 or 20 minutes. And that actually happened with some of the injection. Not everyone felt better within the half an hour, but a lot of folks did. And then this is a follow-up for that case. So following daily contact for Qualtrics, which we just did a follow-up survey to see how they were feeling. They texted the study coordinator and said, thank you, we're really grateful for this treatment. On day 7, they disclosed that they bought a bag just in case they got really sick, but didn't actually need it because the medication worked for them well and treated their symptoms. And that they did have some ongoing marijuana use. And then this is folks who had day 7 urine follow-ups, and they was only positive for buprenorphine and THC. So I have a couple other cases just to go through, and it's just to sort of, again, give you a flavor of sort of how this medication works and how the patients that we enrolled, at least some of the patients that we did enrolled did. So this is a case that was enrolled in RED. There was somebody who came in with opioid withdrawal, was requesting inpatient detox. That's certainly something that we see fairly regularly as people come in and are requesting inpatient. Certainly we all know that is not the best treatment for many patients. Medication is the most important thing. And so this was somebody who, inpatient detox was not available at the time, and so we enrolled him to study just to get him started on medication. So he'd previously used 1 bundle a day of IV fentanyl use and occasional marijuana. And his last fentanyl use was around 6 hours prior to arrival. So his initial CALS was a 9. His urine was positive for fentanyl, cocaine, and THC. And this is somebody who, within sort of the first half hour of getting the medication, actually felt much better. His CALS sort of went down to a 5, and then was down to a 3 before he left the emergency department. And so, again, this is somebody who says they feel great on the medication. They followed up at 7 days at one of our outpatient ambulatory treatment clinics, was actually not able to find inpatient, which he was looking for, but the fact that we were able to get medication in him for the 7 days was something that was something that didn't preclude him from being able to go to inpatient, but is something that where we're at least able to make sure that he is getting medication and is getting some treatment. And so overall he was doing very well and wanted to continue on the injection. How are we on time?
We have 2 minutes.
2 minutes. Okay, so this is the last case. And this is a little bit more complicated, and this is actually one of Andrew's cases. We pulled this for something else. So this is somebody who came in requesting to stop fentanyl after multiple unsuccessful induction attempts in the past. Just says, I can never stick with it. He started with street Norco and then heroin and IV fentanyl about 1 gram per day. And he is a housed single male. So his last fentanyl use was about 9 hours prior to enrollment. His urine was positive for marijuana and fentanyl, and his initial COWS was a 6. And again, this is a patient that we had sort of, we have a lot more data on because they were part of the ancillary study, including the pupil size, which is something that we can certainly be very, very helpful when you're trying to gauge people's withdrawal symptoms, over the course of seeing how they're doing with the medication. At 30 minutes, COWS went down to 4, 3, 4, so those are pretty much the same. So withdrawal symptoms got better. You can actually see that his pupils actually went from 6 sort of down to 4.7 over the course of the time also. So, objectively also getting better. So for treatment and follow-up, so he is somebody who, so in the morning had a little bit of nausea associated with the medication, used a tiny bit of fentanyl the next morning, and then had a televisit outpatient and was still sort of having some craving and some withdrawal symptoms, to which he got very patient-centered care and actually got additional sublingual buprenorphine on top of the injection. And so I think that's an important thing just to realize, is that there's no reason that you can't get sublingual on top of it, particularly as you're initiating someone on this treatment. So his urine screen was only positive for buprenorphine, THC, and benzodiazepines. And then he's actually somebody who went straight from the week-long injectable to Sublocade, and actually did very, very well. So I think at the time that we collected this, wrote up this case, I think he had been in treatment for 3 or 4 months. So overall was doing very well. So with that, I'm going to hand things off to Andrew.
Great. Thank you, Kate. And first of all, thank you all for coming. This is really great. I know there's a lot of competing subjects and things being taught that are very fascinating. So thank you for coming to this talk. I think you'll find that the best people in emergency medicine do this. I'm totally serious, right? So if you're new, I hope you make some friends. And if you're getting long in the tooth with this, I hope you stay. Because I really do think this is very much, the major issue that's confronting emergency medicine right now is how do we expand what we do to meet the need. Those statistics that Gail showed, right, they're really pretty remarkable. So we have to figure out how we're going to meet that. So thank you for coming. Okay, I am thrilled to talk to you about high-dose inductions because we do a lot of them. We have a very, very high volume practice, not as high volume as Rachel Harrah's, who has the highest volume that I know of in the country, but really high volume. So on any day, 10 inductions, so inpatient, ER, clinic, all over. Been doing this for years, so we've got thousands of inductions that I've personally done. I'm just curious, who in here has given someone buprenorphine? Awesome. Okay, fantastic. Great. Okay, that was what I'm hoping for. Okay, so first of all, I made a commitment. I put this in every single one of my slideshows. We as physicians have to engage on this. I don't think any of us think that our person that we're caring for in the emergency department should go out and get arrested for using drugs. That's just not a solution. Again, I work with in my own hospital system, and then I do a lot of work in California. So work with 150 other hospitals, and problems tend to roll up to me in some way or another. So I've seen a lot of things go well and go wrong. Okay, so this is just a standard case. As we get started here, 36-year-old male, he uses fentanyl. It's been a day or two. He's looking like he's in withdrawal. He also uses crystal, so it's a little confusing. How many of you have been told that you should use a lower dose if people use fentanyl? Anyone? Good. Keep it that way, right? This is a true existential threat to the entire project of expansion of buprenorphine in the emergency department. It really and truly is. You will encounter it. So I'm glad that I can give you this buffer before they get to you. There will be a hospitalist-based or ambulatory-based addiction specialist who will come in and tell you you need to change everything when you are working with someone who uses fentanyl. I'm here to tell you they're wrong. okay? So keep on chugging, and if you need data or backup, reach out to any one of these people, right? Okay, so the basic treatment is going to be high dose, right? Because, no suspense. So let's talk about it a little bit. Why? One, we're ER docs, it's faster, right? It just comes on, there's no reason to drag out feeling well for 3 or 4 days. We want things that are quick and definitive and simple, right? That's the core of what we do, and it tends to also be what patients want. They don't want to hang around for hours and hours. They want to feel well. The people we're working with, like this guy that we're talking about, who uses crystal meth and smokes fentanyl, his overdose rate is just astronomical, right? So as quickly as you can, you want to get a full blockade. And a blockade means you've got a ton of bup on board that's occupying all of your receptors, so if you go back and you shoot fentanyl on top of it, you don't die. All of us want to feel like we've given someone a nice, a life raft, basically, after they leave. 2 milligrams is not going to do that, right? It has virtually no protective effects at all, whereas 32 is going to be a substantial protection. So getting that blockade, and it lasts for a long time. We all know that this sort of chain of actions you have to do to sustain just basic buprenorphine treatment is incredibly fragile. It's hostile. Tiny trivialities can disrupt continuity of care. You don't have your ID. They didn't put the diagnosis code or whatever, and all of a sudden you don't get your bup prescribed. So having a dose that's going to last for 1, 2, maybe 3 days just makes all the sense in the world. Why can we do this? Buprenorphine is really remarkable, right? I mean, it was evolved out of a broad multinational effort to develop an opioid that was less addictive and safer than the existing opioids at the time. And they succeeded. It's really a pretty remarkable drug. So the respiratory depression, meaning you give a ton of bup and they don't stop breathing, it's really very true. We've seen it in studies for decades now and in clinical practice. Like, it just is not something that happens. So the complexity here is, while there's a ceiling for respiratory depression, in terms of this idea of symptom withdrawal, we don't really know where the ceiling dose is. Is it 16? Is it 32? Maybe it's 20 milligrams IV push. We don't know, right? So at this point in time, there seems to be a clear linear relationship between the speed and magnitude of resolution of your withdrawal and the volume of buprenorphine that's given. So this is one of the only studies, it's an old study, it was back when they're doing the detox, where basically the slow sloping line is someone who gets 8 milligrams every 8 hours, and then the line that just dives down where the cows goes way down, or not the cows, but the VAS equivalent of cows, goes way down really rapidly, is the person who got a 24 milligram single dose, right? So we know that this works, it works quicker. In terms of putting it out there, that's the studies, small scale, but does it actually work in the ER? I can tell you personally, through 579 cases of which I supervised at some level, almost all of them, there were no episodes of excessive sedation or respiratory depression due to buprenorphine. So high-dose buprenorphine is safe, and as far as I'm aware of, there's no literature to suggest otherwise. Okay, to understand how this all works, some things to know. There's not this precipitated withdrawal and then feeling great and nothing in between. It's this constant continuum of synergy where buprenorphine is going to be working with whatever agonist is residual in the system, and antagonism. And that those things will happen in different sort of pathways in the body. So you can get really confusing clinical pictures where they're along the sort of pain axis or anxiety axis or autonomic function like pupils axis, they might be in a different state between antagonism, like full antagonism would be full-blown precipitated withdrawal, and full agonism would be like, hey, I feel good, I feel kind of high, right? So they'll be on some continuum there, and it might not be consistent. So when you go out there and do this, you're going to see clinical pictures that are confusing, and that's normal, it's okay, it's how buprenorphine works. The other thing is that, this is really came to me yesterday talking with Rachel Harros, who really brought this up to me. It's just this idea that some of the actions are not continuous in time. So we often see this pattern where you initially get a dose and you kind of feel this glow. Like you see it, they're like, whew, they're feeling better. And you think, boom, done, right? And then you get, Dr. Herring, back to room 2, and they get worse again. And so there's probably some situation going on where you have initial synergy, where they're working together, right? We see this a lot in pain medicine. And then the displacement effects of buprenorphine, which are quite rapid, are a little bit ahead of the building agonism. So there's just this molecular reality that buprenorphine has to assemble on the receptor to really get that full agonist signal going. So it's sort of the snail here, right? So you can feel worse, and then if you keep going with bupe, you're going to feel better. So the clinical error here is sometimes when someone gets a little better, they get worse, they think, oh God, here it comes, horrible precipitated withdrawal, stop giving bupe. That's a mistake. That's when you put on the gas, you go harder to get to this eventual place of a positive opioid balance. The way to think about this, this is our guy, he's using fentanyl. I consider fentanyl a shark, right? A shark. I call it a shark because the receptors are afraid of fentanyl. So if any of us, we go into the lab and I put you on a remifentanil drip, very quickly, within hours, your opioid receptors are going to pull back. They're going to pull off of the membrane surface and they're going to hide. Because if they didn't, your system would be overly stimulated with agonism. So they pull back. And it doesn't take much fentanyl to do this. So then you go into acute withdrawal, the sharks have left, and all your receptors come out. When the receptors come out, you're ready for bupe, right? So if you've got receptors that are open, that's when you give bupe. If you give them a low dose, right, there's two kind of things that happen, and you will see this. There are good studies where some people really, bupe doesn't fight with the agonist. So if you can do a trial where you randomize to fentanyl plus buprenorphine, or buprenorphine alone for just pain scores. It's actually the fentanyl plus buprenorphine together that has the best pain reduction on cold pressor tests. So synergy's real. But the more commonly, right, is you'll get someone who, they just get a little bit of bupe, right? There's enough fentanyl in the systems that the receptors don't come out, and you just get this partially treated withdrawal. And they linger along, and they feel like this doesn't work. So they end up in persistent withdrawal. So we see this a lot. So they get 4, they get 8, and they don't seem to be getting better. So here, the solution is just to maximize what bupe does, right? All the good things, which are promoting receptor recruitment to the surface, promoting upregulation of the G-coupled downstream mechanisms of opioid signaling, and just maximizing the on state, right? Because it's always on, off. Just maximizing on is how you're going to get your effect. So in some cases, you'll go 32, you'll go 48, you'll go 64. Sometimes you go high, right? And in fentanyl, basically, the tolerance is huge. There's a pharmacologist I work with, Mark Greenwald. He calls it the neuroadaptive hurdle. Basically, that means your depth of tolerance, right, is greater with fentanyl because it's so strong. So it means that you've got more work to adapt, become sensitive so that buprenorphine can do its work. In that setting, you need more, not less. So the greater your tolerance is, the more bupe you need. And as time goes by, what you'll see is that people don't need giant doses of bupe forever, right? So day 1, they might get 32, 48, whatever. They might be very happy at 16 milligrams a day on day 3 or 4. Because it was this initial period where you're getting out of this profound tolerance from fentanyl, moving toward a more receptive state that is happening in the ER and being promoted by the high dose. So it's rapid, it achieves a blockade, it's long-lasting, and it's simple. So that is high dose. Last caveat, if things go really squirrely, ketamine is the magic goddamn bullet, okay? Just mark my words, right? You get into trouble, you're like, oh my God, and what's going on? Just give them ketamine. We can do a 4-hour lecture of why that makes pharmacologic sense. I won't leave that. I won't do that now, but trust me, it makes sense and it works. Okay, so thank you. And with that, I'm going to pass it on to Rachel.
Thank you, everyone, and thank you for this opportunity to present some of our work that we've been doing in Camden, New Jersey. Unlike a lot of these guys, we're not really these heavy researchers. We don't have all these, grants to do research, but what we do and we do well is we do the work on the ground, and we try innovative stuff, and if it doesn't work, we try something else. So let's see. Okay, so I'm just going to give you a scenario, probably one that a lot of you have seen in your practices, and that, on the streets of Camden, ALS gets called. This is back in 2018. They come to the scene, unresponsive patient, clearly opioid overdose. They give the patient Narcan. The patient wakes up, and they notice, this is in the basement of this old building, and in Camden we call them bandos. They're just these abandoned buildings where a lot of people squat. They notice on the floor there's these, old ambu bags. There's old discarded naloxone. Everybody's angry, the patient's angry, the people around them are angry, and the medics leave and they just feel just such burnout and just, what did I actually do here? And they come over, they come to us. The patient doesn't want to go with them, right? So they're like, all right, I guess I'll leave here until the next time you call me. And it's really not good for anyone. It's not good for the patient. It's not good for EMS. What's crazy is that right down the street, you've got us. You've got a large healthcare system. We've got 635 beds, tertiary care. We've got basically anything you would want. We also have about 5 to 15 overdoses a day and really high morbidity. And you can see here in just one quarter, we had 64 cases of endocarditis, right? Just an incredibly high burden of disease from drug use. Now, at Cooper, even back in 2018, 2019, we had a very robust addiction service. We built it starting back in 2015. We have outpatient, we have inpatient, we have perinatal, we have integrated HIV, we have a fellowship. We had all of this right down the street, right? We had an ED that back in 2016, we started prescribing. We felt like we were right on the forefront. But the thing was that down the street, where the actual patients were, we weren't getting to them, and they weren't getting to us. Now, here you can see, I think this actually, oh, I didn't mean to do that. Oops, all right. You can see right over here, that really tall line kind of a meeting, that's Camden County, and that's naloxone administrations back then. Right, so our paramedics and our EMS and our law enforcement are administrating just an incredible amount of naloxone. But these patients, at the time, because drug use on the streets was becoming decriminalized, law enforcement wasn't showing up and taking them. They weren't giving them that option, or you go to jail or you go to the ER, right? They were saying, all right, you can do what you want. And the patients were refusing. So our refusal rate at that time was about 40%. So 40% of patients were like, screw you, I'm staying here. So we had this amazing healthcare system and that was offering all this addiction care, and yet the patients weren't getting to us. And that was burning out our EMS service. They were just so frustrated. They just felt like they weren't really getting anywhere. What are we even doing here? Why are we even reviving these patients? Our refusal rate of 40% was getting noted by the higher-ups, right? So it was getting noticed by the state, it was getting noticed by the CDC. And so then we all of a sudden were offered this grant. They're like, oh, here's $250,000. We want you to send counselors out, because 40%, that's just not a great refusal rate, right? We want you to send counselors out to the field to talk to these patients, to have them come in. Now, and one of the ideas was even, hey, the patients should just use their smartphones, and we can do telemedicine. Now, for those of you that have been out there, like it just wasn't feasible. But so we sat around this table and we thought about that. Okay, well, they're giving us this money. What can we do? What can we do that out in the field that is actually going to be meaningful, right? What is meaningful? What is sustainable? And what will actually make a difference? And so, and before I go on, I just want to tell you a little bit about our Cooper EMS. One of the notable things is that we run it, right? So not everywhere does the healthcare system run its own EMS service. We do. We run our ALS and we run our BLS. We've got 5 ALS units, 8 BLS units. We do have 1 community medic. We have about 35,000 calls, and the number 1 and number 2 are OD and unresponsive, all right? So what we decided is we said, listen, we've got these people out in the community that are trusted, right? So when you have a problem, when you call 911, the paramedics show up. Let's use them to start really the medication that we know is life-saving and can make a difference. And we sort of took a leap of faith. Now in New Jersey, unlike a lot of other states, we're super heavily regulated. which meant that our paramedics at the time, it wasn't legal for them to actually administer buprenorphine. So one of the things we did have to do is go back to the state and ask for an exemption, and we did get it. We had a commissioner of health at the time who was a physician and saw how unique and this was and the potential for it, and so he did pass this executive directive. While we were working on this directive, we were really hoping it was going to happen. What we did is we actually went back to our EMS service and we had to create a culture change, right? And I can tell you the first time I and a therapist went to our EMS and I gave them a lecture about the neurobiology and the medicine, et cetera, and it was kind of a disaster. So they were angry and they were like, this is crazy, you're gonna be offering drugs to drug users, this is ridiculous, they need tough love, blah, blah. And this kind of went on. Now, we just kept going back and we just kept engaging them. And then what we did is we took our paramedics and we had them come to clinic. And we had them spend time with clinic. And really for the first time, they were able to see that those patients that were in the basement, those patients were actually, they were human. I mean, they were like, really, like when you saw them in clinic, they were totally different. And so it really took that, and then we sent them back out, right? So you kind of like a train the trainer model. So we did live instruction, we did webinars, we had journal club, we brought them into clinic. And then the other great thing is that we do have an EMS fellowship, so we were able to send the fellows out in the field, so our physicians and our fellows out in the field to sort of model behavior. And at the time, we weren't yet administering buprenorphine, we were just teaching them engagement skills, right? How to talk to these patients, and just model this kind of behavior. Now here you can see, and actually I'm going to skip this one and just go to the next thing because this is just a very simple demonstration of what we decide to do. Now our executive directive was a little bit limiting because it was the way it was written is it had to be an overdose and the patient had to have gotten naloxone. And so the way the algorithm ran was the patient, obviously had OUD, overdosed, received naloxone. And then we had several exemptions. You couldn't have received methadone for 48 hours, which now I don't even know that we need to do that. You couldn't be pregnant, which again, really not necessary because you can be pregnant and get this, but we had to have some exemptions. And then you had to be awake and alert enough to be able to give informed consent. You had to have a COWS of over 7. I will tell you since then we've gone down to about 3 to 5, and really we don't care about COWS anymore because these patients all do well. And then the patient got 60 milligrams of sublingual buprenorphine. I will tell you, we started off with tabs, and the tabs simply didn't dissolve quickly enough, and so we had to switch to the strips. Patients did better with those. So we gave them 60 milligrams of the sublingual strips, 4 milligrams of Zofran, I don't know what happened with Zofran, and then, if needed, they got a redose of another 8 milligrams. And then they got an appointment card for the very next day. In the beginning, we had to do that with community partners, and then as COVID hit and we had a walk-in clinic, they really just all get referred to us. I'm just putting this up there. We did publish that pretty early on, and if you want the algorithm, it's all in there. So some of our early data, we offered Suboxone to over 1,000 patients and about 10% accepted. 44% made it to their first appointment, which in the world, honestly, in the world of addiction is really pretty incredible. And about 61 of those actually made it through the first month. Our average on-scene time was 24 minutes. And for those of you in EMS, for us, it only increased on-scene time by 6 minutes, which really kind of decreased that stress for everybody because that was one of the other issues was, oh my God, are you going to be on scene for 2 hours? Like, you can't do that. Not in the city of Camden where we have such high acuity. And then just, as more data rolled in, we found that, the average Narcan that had been given was usually about 2 milligrams, although now that's changing because so many of our bystanders have the intranasal, so everybody's getting 4 and 4. Our initial COWS scores were about 9, just around 9.6, and our post-bub average was about 3.3. I will tell you one thing, nobody got worse, right? Right now we're up to about 178 patients, and nobody has gotten worse. We have not precipitated a single person. Every patient got better. We did have some barriers. One of the biggest ones is that our patients are terrified of being precept, right? So if they're already got Narcan and then we offer them the Suboxone, they're like, no, I'm gonna get, I don't want to have precipitated withdrawal. Another one is that some of our patients just, even with 4 milligrams of naloxone, they don't actually in withdrawal. And then of course the on-scene stress. One of the other issues was that we trained our medics and everybody was kind of on board. And then as time went on, they just, it kind of faded. So we really needed to have the physicians out there motivating, modeling behavior, and encouraging the paramedics to do this. We were very lucky, I will just put that out there, because we had an ED that was already actively bridging, and it was part of our culture. Our EMS system was run by EMS, and we had a very robust addiction medicine division that could absorb these patients. There was a silver lining to this. Our focus when we did this was really on the patients. We wanted to provide better care, and we wanted to engage with this population that wasn't engaging with us. But that absolutely happened. But the kind of the better part of it is that it really changed the culture for our EMS, and they started feeling like they were motivated to come to work again. Their burnout decreased, and they felt for the first time like they were part of the solution. So that's all I have. Do we want to take some questions?
Yep.
Okay, great. So you must have some questions, and because it's being audio taped, I may have to repeat the question, and then if you want to come up here, or you think you can scream, it's fine with me. You must have some.
Well, I have a few questions. How many of you have given buprenorphine after naloxone reversal? Did it work? Kind of amazing, right? It's a problem that that's not standard of care, right? Because it just works. So those people who didn't do it, were you in a situation that you could be instructive, or like where you thought you might do it, be like concerns or any questions around it?
That was kind of my question. My name is Brad Gordon, Health Partners, St. Paul. We're finding that we just are microdosing the Narcan so much that we get these people kind of in sleepy, like nobody's really feeling like they're in fluid withdrawal like they were 3 years ago. And then we kind of watch them for 2 hours. And, we try to get some in the window there, but I think a lot of our providers are feeling hesitant that they're not seeing these high cow scores in this group. And it sort of feels like a missed opportunity of a patient who would overall be a candidate, obviously wanting to transition them to MAT, but maybe not at that window. So starting to try to do more start kind of discussions with our providers and get that more, but we're still feeling maybe that's a big window of people we're missing. So any advice on that group? Or
When you say microdosing naloxone, what numbers are you talking about?
like 0.1, 0.2 people are giving.
Okay, and that you do that in the ED?
Yeah, there's a little bit of like that, hey, they need a little more, they're a little apneic, let's do that. And,
Okay.
because they're getting intranasal, and then maybe they have some symptoms, or they're triggering, the Untitled or something.
But when they got the intranasal, they got 4? Or do
They
you
often
also...
get less. They often are getting 2 intranasal in the field.
Okay. I mean, I will tell you, right, so 2 intranasal in the field, plus whatever you're giving them in the ED. I will tell you that we started off with 7, and our medics were like, people aren't at 7, they're like 3 or 5, should we still do it? And we're like, yeah. So we did it, and nobody got worse. It's almost like there's something about the naloxone already being present that creates almost like an opportunity to get slide the bupe in.
Well, that's kind of where I'm wondering, is if we feel like from years of, I'll call it just office-based research, you got to have this full withdrawal, high cows, and now we're kind of like, no, you're actually being kind of relaxed, but you have the naloxone on board, and you're still not seeing the precipitated withdrawal. And it sounds like, you've opened up a lot of your windows of just treatment parameters after baby stepping in, and you're finding that there's not a downside. So that's very helpful.
Our rule of thumb has been, and I'm interested to see what Rachel thinks, they need to be awake.
Yeah.
If they're still like, I haven't given bupe to someone who's still like kind of
Right.
knocked out. But if they're up and you can talk to them,
Talking to them.
that means they've got a lot of naloxone on board that's actively initiating this process of resensitization, which is creating a field for bupe to work. So
Yeah,
is
I
that
agree, totally agree.
Okay, thank you.
Hey y'all, Walt Schrading, UAB. In the pre-hospital group, they get a single dose, correct? Then what's the follow-up? How do they bridge to care after that?
Yeah, sorry, I should have been more clearly. So they get 1 or 2 doses. So they start off with 16 milligrams and a little bit of 4 milligrams of Zofran. And then if they're a little better, but not a lot better, they can get a single 8. And most of ours will get a second 8.
So the medics stay with them for some period of time to
right.
keep watching them.
Right, but not long. Average
You
time
said
24 minutes.
yeah.
And then what happens is they get a card with a next day appointment. Because we have a low barrier walk-in, they all just come to walk-in the next day.
Okay, so they can get next day. Fine.
Correct.
Okay.
Hey, cool presentations. I just had a question about the high-dose bup. So I know there's like a lot of algorithms with like dose adjustments and trying to find the right dose. So if I give someone high-dose bup in the ED, I get them to the dose where they feel okay to leave, and they can't get followed for like, I give them a referral to the addiction clinic, it's not gonna be an appointment for another 5 days or like a week. Should I just send them on that high dose for the whole week, or should I try to have them adjust their own dose at home? Like, how
Yeah,
much
that's
should
a
I
great
send
question. I think that in general with buprenorphine, stepping down is better than stepping up in the sense of, if you, hypothetically, if you're going to err on the side of too little, what's the downside? Oh, well, they'll be less protected from overdose and will have more craving for a street drug. What's the downside of giving them too much? It's kind of hard to find one, so I would say always err on the side of more, right? Because then again, people, it's a real world. Survival strategies are complicated and, idiosyncratic, and so people, if they know they've got a lot of bup, then maybe they miss their appointment. It's not like a terrible situation or whatever. So I just think we know that the problem is there's not enough bup in the world. So getting bup out there is just all of our responsibility. Pharmacists, primary care docs, ER docs, is just get it out there and don't sweat the details.
But I think if you're giving them 48, I wouldn't discharge them on 48 a day. Like I probably would do 16 to 24, and usually our ER docs just do 16. I don't think it's crazy to do 24. We do 24 from clinic a lot. I don't know that I would start someone on 32 every day.
Well, the insurance companies don't cover it.
And do you kind of give it to them and say take this much, and if you're not feeling good in like an hour or two, you can take more, or like do you have it more specific instructions? Like, is it more rigid, or do you let the patients?
So I'll say take
decide?
8 twice a day or 8 3 times a day. If you're kind of sleepy the next day, take a little less.
Okay, cool. Thank you.
Yeah.
Appreciate it. There seems to be a lot of confusion at my shop regarding the X waiver and what you exactly need to do this. Is it state dependent? What is y'all's experience with that?
Could you just tell us who you are?
Oh, Sally Peterson, or Prisma Health Upstate, South Carolina.
So I'm going to see if I can actually pull up the SAMHSA website. So you do not need training to get a data waiver if you are treating less than 30 patients at one consecutive time. So that applies to almost any emergency physician or advanced practice provider in the field. So this, if you just Google, no, that doesn't work, never mind. So if you just Google SAMHSA buprenorphine, they'll come up with a link where you can actually just go through and apply for your notice of intent. And you just need your NPI, and that's it.
And to administer it in the emergency department requires no certification at all.
So the one other thing that happened that may also be contributing to confusion was this idea of the 72-hour rule, which is that you can, without an X waiver, you could have somebody come back to your ED daily for up to 3 days to get a dose of medication, either buprenorphine or methadone. And there has been recent policy change that you can actually discharge somebody with 3 days or 72 hours of treatment with a plan to follow up without an X waiver. But
You have to apply for that. Then you have to apply to the DEA for that, which you can write them a letter. But if you just do the SAMHSA thing, you'll be covered.
Hi, I'm Corey from Lincoln Medical Center. You mentioned that if you run into trouble when you initiate bup, but I kind of have 2 related questions.
Yeah.
If you're into trouble, you like to give ketamine.
Yeah.
I thought you would have just said give more bup. So I'm wondering why you give ketamine
Together.
Oh, okay. You give more
Yeah,
bup
so
and ketamine.
yeah, just like you've all used ketamine probably for folks who are opioid tolerant, and you're trying to reduce your reliance on Dilaudid or whatever.
Yeah.
It's the same thing. It potentiates opioid signaling, and it inhibits hyperalgesia, which in withdrawal in many ways is sort of the apotheosis of hyperalgesia. It's like the worst possible hyperalgesic state you could have. So it makes your bupe work better and faster.
Cool.
So I would just do 16 and 20 milligrams of ketamine.
That's what I was gonna ask, was what kind of doses of ketamine do you use?
Yeah.
Well, and I think the one important thing about that is sometimes it takes nursing a while to get the ketamine together and pull it up. I would not like get the bupe, like give them the bupe while they're messing around with the ketamine. Don't not do anything until they have the
Right.
ketamine pulled up, and you know if there's going to be delay in that, if that makes sense.
Yeah, and then last question, are you just pushing the ketamine IV? Mm-hmm. Okay, cool.
Yeah. They're very receptive to ketamine, so they just get the good parts. Yeah.
And I think we're actually, it is 1:58, so I think we're probably at time.
Oh, come on, Ryan.
Hi, I'm Ryan from NYU in Bellevue. I was just going to ask, some of the hesitancy I've seen with post-naloxone is when you're not sure of what other substances they've taken and which opioids and how forthcoming the patients are being, and whether you kind of require that they tell you that they're on heroin or fentanyl and not taking methadone or other co-ingestion, and how other co-ingestants modify your behavior.
I mean, honestly, for me, bupe plus everything else is still better than fentanyl plus everything else. So I'm always going to opt for bupe. As far as the methadone goes, I'm just trying to be very transparent. I'm like, hey, if you're like actually going to a methadone clinic, then me giving you this may make you feel bad, so you're going to need to let me know. And I feel like patients are pretty forthcoming if they actually are on methadone. And for everything else, I still feel like it's a harm reduction improvement overall.
And we basically took Rachel's program and tried to replicate it in Contra Costa and had the same exact experience. And we've had a couple of methadone cases, and it's actually has been a very smooth ride. They are in withdrawal from naloxone, they get bupe, the bupe wears off, and they go back onto methadone. There was no fireworks.
Cool.
Okay,
Thank you.